Start chesina? Okay. How many of you? Sorry for the delay. I got it late. I did not know it was my class, but yeah, it turned out to be mine. Last time I finished with arterial system. You guys have not asked any questions, so I think that you know everything in arterial system, and I'm moving to the venous system. Arterial system is a 5-star. Questioning in your entrance questions, because almost on every year, an yearly basis, arterial system has got a question. If one question is a must, two is a bonus. Arterial system is important. Then the venous system and the lymphatic system. Venous system also is important, but it is not like arterial system where every year the question comes. Venous year, sometimes it comes, sometimes it does not come. Sometimes they club the venous system into the super speciality, that is CTVS, cardiothoracic and vascular surgery questions, especially pulmonary thromboembolism. So we have to be careful, and because venous system is a practical point of view is an important system, because you will have a varicose veins as a compulsory long case. Then you will have venous ulcer as a short case, and there's so many questions that will be asked in venous system. So let me not waste much of time, because already I'm starting the class late, because I did not know it was my class. So let's get into the topic. As I told you, artery is anything that carries blood away from the heart. Vein is anything that brings blood to the heart. So all the venous system, lower limbs will go into inferior vena cava, followed by they join the superior vena cava into the right atrium. So they all go that way, and you have your pulmonary veins, which carry pure blood, from oxygenated blood from the lung into the left atrium, followed by left ventricle, and will be distributed through aorta from there on. So you have to understand why this venous system is important, because number one, there are so many anomalies. Like arteries need not have anomalies, veins have a lot of anomalies in their formation structure, and as well as the system itself. Number two is because the venous pressure is always low. Okay, the venous pressure is low. Why? Because it has to match the right atrium. Right atrial pressure is so low. So the same thing, venous system will have the pressures low. But one particular venous system, that is different from this axis is your lower limb venous system. The ambulatory venous pressure of the lower limb is 80 to 100 millimeters of mercury, which is as big as your arteries. From there on, yes, as it moves up, the venous system pressures fall, and by the time they reach the right atrium in the form of superior vena cava entering it, it is almost negligible, about 6 to 8, sometimes 10. So that's how it falls. But ambulatory venous pressure of the lower limb itself is 80 to 100 millimeters of mercury. You can imagine it's as good as the arteries. Why? Because it has to flow against the gravity. So there are so many complications that venous system of the lower limbs can develop. So we have to understand that venous system is important. The first and the foremost venous system that we will be studying, at least for today, is the superficial system and probably the deep venous system. I'll complete them. Actually, I'm a little late. I feel bad. Otherwise, I should have spoken a little more. But it is not possible right now. I'll be talking about the superficial venous system as well as the deep venous system, if time permits. So I have time till 11:15, so I'll push it a little. It's already 10:51, so I can't really be taking the class for too long. So I will start and complete it off. So basically the lower venous system is superficial system and the deep system. Superficial venous system consists of two major veins. Okay, two major veins, 80 to 100 millimeters of mercury ambulatory venous pressure is an entrance bit, please remember. So two venous system, two veins, two major veins, okay, two major veins and their connections to the deep veins. Okay, deep veins are the popliteal vein, okay, deep veins are the popliteal vein, followed by the femoral vein and then external iliac vein, common femoral, external iliac. So it goes like that, and the deep veins of the legs are not really big, that's antitibial and all, but we are not really concerned. Superficial venous system, you have great saphenous vein coming from the medial aspect of the ankle, around the ankle joint, and then it slowly passes around, stays in the medial aspect up to the thigh, and it is closely related to the largest branch of the femoral nerve, and that nerve is called as what is the nerve? And it is a very important question. Every Viva question is based on that. Whenever they ask you about stripping, they ask you about this vein. This is called as, yes, it takes the name as saphenous nerve. It is the longest branch of the femoral nerve, please remember. Okay, largest branch of the, and it is purely sensory. It is purely sensory. It's called as saphenous nerve, most commonly injured during both endovascular laser surgery as well as stripping. So whenever you are asked about this question, you should be knowing. So then it enters the thigh, okay, it enters the thigh, goes up and then drains into the deep vein, that is the femoral vein at the SF junction. SF junction is about 2.5 centimeters below and lateral to the pubic tubercle. Please remember this, 2.5 centimeters below and lateral to the pubic tubercle, you have the saphenofemoral junction where the saphenous vein enters the deep vein, that is femoral vein. Okay, and then you have the short saphenous vein that starts at the lateral part of the ankle, then moves up laterally and enters the popliteal vein, and it is only 25% of the times popliteal vein. And this particular thing exactly is at the knee crease. In only 15% of the cases, 25% of the cases, it drains at that particular site. Otherwise, it is 25% of the times up. Okay, so 25% of the times up. Sometimes it is lateral, sometimes it is posteromedial, and sometimes it's anterior. So the short saphenous vein entering the popliteal vein is not exactly in the same location always, whereas it is in the same location for the saphenofemoral junction. Saphenofemoral junction is 2.5 centimeters below and lateral, okay, below and lateral to the pubic tubercle. You have to remember this particular surface marking. You cannot miss it. And the long saphenous system has about 6 perforators. One is at the mid-thigh perforator, also called as DODS, D-O-D-D-S, DODS perforator. Then you have one below, and that is called as Hunter's perforator. And three of them are leg perforators. Two of them have name Kushner and Roth. I think I don't remember precisely the other name. Kushner and one is Kushner. Kushner is guarantee. TOTS, T-O-T-T-S, if I'm not wrong, dots or TOTS. I'm a little confused, but yes, you have to remember these names. That is, leg perforators are 3 in number, 2 are named. Just below the knee perforator, I told you already, it is Hunter's, and one at mid-thigh perforator that is called as DODS, D-O-D-D-S, DODS perforator. Please remember all these. And there are 2 perforators. They are not named for the popliteal system. That is, one is at the mid-popliteal and then at the popliteal. And here it is important. Why? Because the sural nerve, the short saphenous system is always in continuation with the vein scores. So the short saphenous vein, sural nerve injury chances are quite high, and that is an entrance question. So what are varicose veins? I already told you the resting ambulatory venous pressure of the lower limb veins, especially the great saphenous system, is 80 to 100 millimeters of mercury, because it has to go against the gravity. It is one of the main reasons the pressure is so high, and the chances of patient developing varicose veins are also equally high. So you have to remember that varicose veins are because of the pressure gradient. More than anything, it is the gravity that is causing this. Number one, gravity. Number two is patency of your valves. Patency of the valves. These valves are the places where the superficial veins enter the deep veins. The perforator is more like a wall, and this valve is weak. That's the reason you develop perforator incompetence. It's not weak, it becomes weak over the course of time. Then the tone of the muscle. Then the tone, not the muscle, tone of the vasomotor tone. It is vasomotor tone. One of the reasons for, if there is any alteration, the chances of patient developing varicose veins are quite high. And number four is the pressure from the venous system, that is the heart, how it is going, and the muscular contraction. The strength of the muscles also is important factor in patients developing varicose veins or not developing varicose veins. That's the reason it is always advisable for any patient to lie down, rest the leg in a 45-degree angle, so the gravity pushes the veins from stasis, which will in turn prevent formation of both that is deep venous thrombosis as well as superficial veins becoming engorged. So how do you define a varicose veins? Tortuous, elongated tortuous veins of the lower limb are called as multiple elongated tortuous veins of the lower limbs are called as varicose veins. So varicose veins, what are the causes for varicose veins? 30% of the times it is familial. There are familial diseases where the patient can develop varicose veins. Number one. Number two, patient long standing, those who stand for a lot of time. So you should know who are the people who stand for a long time. Number one is teachers. Number two is policemen. Number three is farmers. Number four is bus conductors. These are the people, watchmen. These are the people who stand for a very long time. So venous return becomes difficult and venous stasis takes place. And this venous stasis will continuously cause elongation of the swelling of the veins over a period of time. The perforators initially become incompetent and followed by the SFJ, that is saphenofemoral junction. Once they become incompetent, the veins will start having blood in the columns, and these veins are going to cause some of the problems that we will be discussing in the complications of varicose veins in the course of time. So this is what will happen. This is what is the pathophysiology of your all the four sets that I said: the vasomotor tone of the veins, the muscular contraction, the heart effect, and the gravity, as well as the perforator capacity. These are the things that are preventing formation of varicose veins. Whenever there is an imbalance between any of these, the chances of the patient developing varicose veins are high. And whenever you stand for a lot of time, that is hours together, that is what is going to happen. The patient will have, yes, the vasomotor tone decrease. Okay, the vasomotor tone decrease or initially increase followed by decrease, and then the failure of the valve mechanisms. Okay, the muscles sustained contraction, no proper relaxation, that could be one of the reason. And also the blood column in itself, the blood is not reaching the heart as it should reach, so the patient will develop varicose veins. This is what is basically about the varicose veins. So this is the pathophysiology of varicose veins. You should know in detail about varicose veins because it is 4-mark question. They never asked it in long case, but yes, it's important for 4-mark question. Then it is important for your entrance point of view. Not so important as the arterial system, but definitely important. Number three is as I said, exam point of view. That is your practical exam point of view. It is a long case as well as a short case. Venous ulcer is a short case. Varicose veins itself is a long case. So varicose veins won't leave you here. It won't leave you in MS general surgery also. So what are the other causes for varicose veins? What are the things that should happen for a patient to develop varicose veins? Pregnancy. Why pregnancy? Because pregnancy compresses the inferior vena cava and there is stasis of the blood in the lower limbs, and that columns will become varicosities, and once it comes varicosities, it's never going to go. So any pregnancy that causes varicose veins is going to be a permanent damage. So you should always ask the patient who's pregnant to keep her leg elevated, Then any tumors in the pelvis, it is in the pelvis, please remember, in the pelvis, if there are tumors, the patient will develop, the chances of developing varicose veins are high because they will compress the inferior vena cava. So what are the pelvic tumors that you guys know of which can grow to such extent and then cause varicose veins? Yes, it is mucinous or serous cysterinoma of the ovaries. It is endometrial tumors, endometrial cancers, and then also the cervix when it infiltrates, cervical cancer when it's infiltrating your vein, that is inferior vena cava, that is when the chances of patient developing varicose veins are high. And also fibroid uterus. Huge fibroids go up to 5-6 kgs sometimes, so huge fibroids, then these also can cause varicose veins. So when you ask a patient about history, you should try to understand each of it. Family history is important because 30% of them are idiopathic, and the rest of the 40% stand with so many reasons. So it's pelvic tumors, not the tumors of abdomen. It's more about pelvic tumors that are causing varicose veins. So once you know that these are all the secondary causes of varicose veins that have been ruled out, followed which you have to check for other causes of other reasons for development of varicose veins. So varicose veins, a patient has come to you, you've asked history. What is the history that you will ask? Because it's a practical question. I want to stress upon varicose veins here also. So what is the history that you're going to ask? One thing regarding the varicose veins, what are the timings? What is the period of time that these becoming more engorged? Are they having any pain? Most of the times it's because the veins are getting filled with blood. The patient chances of developing a dragging type of pain in the lower limbs, especially the calf region. Okay, especially the calf region, dragging type of pain. You should ask about any color change in the lower aspect of the leg, especially medial side of the ankle. Then you should ask about itching, because eczema is one of the complications of varicose veins. You should ask about itching. You should ask about ulcers, healed ulcers, not healed ulcers. Ulcer that is present now, ulcer that is there, or you should ask, the more precise way is there an ulcer that continuously comes and goes in the same region? Why? Because venous ulcers heal well. Okay, you just give it to rest for about 5-6 days. A big ulcer also will heal. If it is superficial, unless and until it is not getting deeply involved, if the superficial veins easily, superficial injuries or ulcers will heal. So you ask about these: itching, pain, discharge, ulcer. These are the questions that you ask. Then you should ask about patient has any pelvic tumor history. Did they come in pregnancy if it's a female, or you should ask about urinary bladder. Urinary bladder also is in the pelvis. If any tumors of the bladder or prostatic tumors can also cause varicose veins. So you should ask all these urinary habits, whether he's getting up in the night for a long time, a lot of times for passing urine. So that is one of the positive histories. So you should remember and ask the patient about varicose veins. So once you have come, you have to go for family history followed by general physical examination. You will not have general physical examination much of the findings. If the patient has an ulcer, eczema, you could find inguinal group of lymphadenopathy, that is because of secondary due to infection or because of inflammation in the lower limbs. So inguinal group of lymph nodes can be active, can be increased in size. and after which you will come below, and then you will start examination. There are four or five tests that you will perform, that is Broadest test, wherein you should do it as 1 and 2. Broadest. So how do you do? First, you ask the patient to lie down, milk the veins in total, and then block the SFJ junction. Already I told you, 2.5 centimeters below and lateral to the pubic tubercle. Ask the patient to stand. Okay, ask the patient to stand. You see if the column of the blood is filling from below up. If the column of the blood is filling below up, in spite of you blocking the SFJ, which means it is perforator incompetence. And when you are releasing it, if the blood column flows so quick and the veins are getting filled from up to below, that becomes Trendelenburg positive 1, which means the patient has SFJ incompetence, number 1. Number 2 is a Perthes test to know about the deep venous system. So you strap the patient or try multiple tonic way, and ask the patient to do some exercise. As he does, he'll have a shooting pain. Okay, he'll have a shooting pain and the veins become more engorged, which means the deep veins are not competent, are not good. There is a deep venous thrombosis, which is one of the reasons for the development of varicose veins. So, which means the patient is not fit for surgery. You cannot operate a person when the deep system is involved. If the deep system has deep venous thrombosis, you cannot operate the patient, because if you operate the deep venous system, if you remove the superficial system and the deep venous system has thrombosis, the patient's lower limb will become gangrene, and ultimately you will lose that patient's leg. Sometimes the chances are very high that you will lose the patient himself. So superficial veins, Perthes test. Then there is Figgins test. You should check for semilunar weaknesses in the subfacial planes of the sides of the perforators to know if the perforator is incompetent. There is a semilunar defect that's called as Figgins test. There are two tests that old timers are very interested to ask, that is Homan sign and one other sign I just forgot. My hypoglycemia is setting in. I'll try to tell it. So these are the deep to check for deep venous system, but they're very, very dangerous. They're obsolete now. We don't do that Hoffman's test and that test. I'm not able to remember. Probably I'll remember and then tell you by the course of time. So you will check for these tests: Perthes test, modified Perthes. Most of the times you do modified Perthes. You do a Broadest Trendelenburg test. Then you will do a Figgins test, and then you'll do a Morrison's cough impulse test. This is basically a inspector is you tap on the Morris cough impulse. You ask the patient to cough, closing the SFJ. Then you will have a blood column hit. That is so common, and we are not really bothered. So once you get these done, then you ask the patient to get a color Doppler done to confirm the diagnosis. Number 1, whether the SF junction is incompetent. Number 2 is if the perforators are incompetent. You'll have to mark the perforators because you're going to perform surgery. And then based on this is the investigation, color Doppler with B mode ultrasound. Okay, you will know the flow, you'll know the column, you'll know the perforators. That's the reason we want to do a B mode ultrasound, and also know the patency of the deep veins, if they're thrombosed or normal. So if they are normal, we don't have to do anything. We can just do the surgery and leave the patient. Then some of the examiners who are coming, they're very much interested in asking about CEAP classification of varicose veins. CEAP classification of varicose veins is: C is clinical, E is etiological, A is anatomical, P is pathological. So C is C1 to C6. C1 is only spider nevi. C1 is spider nevi. C2 is spider small varicose veins less than 2 centimeters, that we don't have to worry. C3 is large varicose veins, okay, with skin changes. C3 is skin change. C4 is C4 is healed ulcer. Yeah, C5 is sorry, C4 is what do you call? What is that called as? C4, C5 is healed ulcer. C6 is active ulcer. C4 is lipodermatosclerosis. CEAP. A is anatomical, superficial veins or deep veins. Okay, anatomical. Then you have perforator incompetence or the SFJ incompetence, anatomical. Then CEE. E is etiological. Etiological is secondary varicose veins or primary varicose veins. Primary varicose veins is familial, etc. Secondary is due to some other cause in the abdomen. And pathological classification is whether the deep systems or the superficial system or the perforator system. So this is how they want to check, and then you have to tell it in detail. So CEAP classification, CEAP classification. You do CEAP, you classify this in CEAP classification, and followed by you ask the patient, you do a color Doppler to know the diagnosis. Once you have made a diagnosis, you have to remember that you're going to treat it. If it's only a superficial, perforator incompetence, what do? You would do a simple subfacial ligation. If it is a SFJ incompetence, that is saphenofemoral junction incompetence, what do? You have to do what is called as flush ligation of the three superficial tributaries that are going to join the saphenous vein at the saphenofemoral junction. You'll ligate those three away from the vein, away from the main vein, and then you will close off the SF junction. Okay, you close the SF junction and then cut the saphenous vein, and then pass a stripper and strip it up to the thigh, up to the mid leg. Okay, or just below the knee or mid leg, or 1/3 of the leg. You strip the whole vein, and the chances of that you injuring the saphenous nerve is so high here, so high. So once you strip the vein, you will then do subfacial ligation of the perforators, and then you tie the patient with crepe bandage so that you won't have any collection keeping there and that causing infection. Once you do this, that should be sufficient. These days there are other modalities of treatment that have come into play, that is endovenous laser surgery. They'll pass a catheter, okay, and through the catheter they'll pass a laser string, and then they continuously burn the varicose veins at 9 joules per minute. And once the whole vein is burnt, they'll remove it and they'll tie the crepe bandage. The post surgical management of both of them is the same, but the advantage of endovenous laser surgery is that the patient can be sent home immediately on the same day or the next day, or to see this thing, and that can be performed in local anesthesia. And the problem is the recurrence rates are quite high in case of varicose veins done by endovenous laser surgery. Here in your flush ligation and stripping, that is Trendelenburg surgery, the plus point is the recurrence rates are low to absent. Recurrence rates are low to absent. You don't have to worry about the recurrence rates at all. So once you do this, you will know. And what are the complications of varicose veins? Varicose veins complications are important because they are asked. Any case that comes with varicose veins to you, you have to remember that there are about 10 complications of varicose veins that you have to remember. Number one is varicose veins themselves. Okay, varicose veins, then they'll cause eczema. Okay, they'll cause eczema, they'll cause lipodermatosclerosis, they'll cause venous ulcers, they can cause deep vein thrombosis, they'll cause equinovarus deformity of the lower limbs, they can cause periostitis of the tibia, and then they may cause something called as Marjolin's ulcer. Marjolin's ulcer is in varicose veins. It's quite dangerous because it will come in an active ulcer, and Marjolin's is a malignant ulcer, so it just starts digging in deep, and it is a vein that it is going to hit, and once it hits the vein, it is going to be a torrential bleed, and ultimately the patient dies. Generally, Marjolin's ulcer is friendly malignant ulcer because it does not metastasize. But in a case of varicose vein induced or varicose ulcer becoming Marjolin's ulcer, that it is quite dangerous because the patient can end up with torrential bleed because of the involvement of the vein just below, and torrential bleed, ultimately patient will die. So we are more worried in of a Marjolin's ulcer in a varicose vein ulcer. So it is important. So it causes periostitis, it causes cubitus deformity, it causes eczema, it causes lipodermatosclerosis, it causes ulcer, it causes that's it. Yeah. These are the complications of varicose veins. So varicose veins complications are also important. You should not this thing. And then there are other complications when deep veins are also involved. That is phlegmesia albadolens and phlegmesia curelia dolens. These are the two things that you should remember. And then because they can cause deep venous system involvement, causing thrombosis. Superficial thrombophlebitis also is one of the complication of varicose veins. Superficial thrombophlebitis is so damn painful. The patient comes with severe acute pain, not even able to walk. So you have to admit, you have to tie crepe bandage, you have to give him painkillers and all. And then there is venous ulcer. Venous ulcer, most of the times it is gravitational ulcer. So you put it against the gravity, the elevation of the limb with Bisgard's regimen, four-layered closure of the dressing. Four-layered dressing of venous ulcer will cause healing at a very quicker rate, and the patient will become normal. The ulcer, but ultimately he has to undergo the varicose vein surgery if he has to have any benefit from the varicose veins. So this is in general about varicose veins. You have to because this is a short question in the final exam. It is also more important in your practical exam. So you need to know in and out about varicose veins and in total about varicose veins. That is about varicose veins. Homan sign and other sign I'm just not able to remember. Probably in the next class when I'm taking, I will tell you about the other sign. Sometimes the brain just does not want to give in. Okay. Then you have the deep venous system. Deep venous system is important because the deep veins are the veins that actually push the venous blood into your vena cava and external iliac vein, and followed by the vena cava to inferior vena cava to superior vena cava, and then join the right atrium. That is how you should understand. But deep venous system is important not because of it's this thing. Number thing is deep veins, if they are not if they are thrombosed, they can cause superficial varicose veins, number one. And number two is the most dreaded complication of pulmonary thromboembolism. Pulmonary thromboembolism is one of the reasons for one of the reasons for pulmonary thromboembolism is deep venous thrombosis. So what are the causes for deep vein thrombosis? Sedentary life, hefty personality, okay, obesity, that's called as that is obesity, Patient who has homocystinemia, okay, homocystinemia, then if the homocystinemia, 1 minute, I want you to ask doubts. I'm just trying to open the YouTube channel of ours. uh, if you ask the questions, I'll try to solve it. Okay, if you ask the questions, I'll try to solve. So the first one to come is 10:48. Okay, and probably he must have left. So you guys are not interested in surgical classes at all. Simran has asked a question: if stripping is done, why there will be recurrence? No, in stripping you don't have recurrence. In endovenous laser surgery, you have recurrence chances. Why? Because we are not going to cut all the accessory veins that come from the venous system. So the chances of that accessory veins getting activated and they causing recurrence is high. And in endovenous laser surgery, stripping in itself won't cause recurrence. No, that is in Simran, I think your question is answered. Stripping won't cause recurrence because you're removing the whole damn vein, so there's no question of that it becoming any this thing. You'll strip off whole of it. So along with it, the accessory veins that are there, whatever small, will just cut off and come. That's the reason we put thread bandage in order to prevent that bleeding from that small accessory veins. But in case of laser surgery, you're just burning the vein. So even if little patency is left and these accessory veins are communicating with that part of the region, the chances of recurrence are quite high. Then deep vein thrombosis, patient with homocystinemia, patient who's obese, patient who's have a sedentary life, all most of the times lying down on the bed. So bedridden patients, and if you do any abdominal surgeries for about 4 to 5 or 6 hours, big surgeries, the chances of patient developing pulmonary thromboembolism due to deep vein thrombosis is quite high. So how will the patient come to you? He will come with excruciating venous pain of the lower limb. He cannot walk, his limbs are swollen, and you will have what is called as venous in arterial system. I told you about it. What is that? Patient will have claudication. Here the patient will have venous claudication. So the patient will come in claudication as he has claudication and severe pain, swollen limb, he'll come to you. You have to suspect deep vein thrombosis because the patient should not be walking. If the patient is walking, probably the vein thrombus will dislodge and cause pulmonary thromboembolism, which is life-threatening situation. So we don't want that to happen. So high degree suspicion, you'll do a color Doppler. Once you do a color Doppler, you will know if the deep veins are not patent and thrombosed. So what you would do, you would ask the patient immediately for a bed rest, immediate bed rest, admission. That you will administer the patient with either low molecular weight heparin, or you will also administer the patient with heparin proper. If it is heparin, you give him about 5,000 international units every 6th hourly, that is 4 times a day. Whereas if it is low molecular weight heparin, you will give about 60 milligrams, sometimes 40 is the most commonly used low molecular weight heparin. It is called as enoxaparin. So you give it, and it acts for 48 hours. You give it subcutaneously, whereas heparin is not given subcutaneously. So you give this thing, the clot starts melting, and then you give the patient, you will start the patient with we'll start the patient with oral anticoagulants, that is warfarin, and this warfarin you will have to continue for the next 6 months. And whenever you're continuing warfarin, you have to see that his PT-INR, the INR ratio is 2.5. That is more important. You have to keep it in the range of 2.5 to 4 if you want a good anticoagulation profile. So keep the patient on warfarin for 6 months, and then you will have pulmonary thromboembolism. Pulmonary thromboembolism is an acute congestion of lung because of dislodgement of a thrombus and blocking the pulmonary veins, so pulmonary arteries or veins, anything, and that will cause stasis and ultimately lead to patient being dyspneic. Patient becomes dyspneic, patient becomes hypertensive, patient goes into cardiac failure. Sometimes the patient will go into total collapse and die. So we have to be careful. So immediately you start, even if you suspect pulmonary thromboembolism, you will start the patient with either low molecular heparin 40 international units or 40 milligrams subcutaneous subcutaneous BD, and if you're giving heparin 500 international units 4 times a day, that is 6th hourly, and then you will manage the patient with warfarin for the next this thing. And if the veins are big, you may have to place a IVC filter, that's called as IVC filter, which will filter that is thrombosis from coming to the lung and then blocking any of the pulmonary vasculature. Pulmonary thromboembolism is life-threatening, so we have to be careful. Deep vein thrombosis is one of the reasons is superficial varicose veins, as well as deep veins can itself cause varicose veins. So you will have to ask the patient to rest. You'll have to not compress anything in the beginning, no compression in the beginning. For prevention of deep vein thrombosis, you apply compression for patients who are undergoing a long surgery, and those who are lying down for a who are bedridden, probably will do a compression bandage to prevent deep vein thrombosis. But once deep vein is suspected, you will not apply the patient with any crepe bandage. Okay, right, it is already 11:28. Any more questions? One more complaint of patients with varicose veins. What to ask for patients in complaint? Okay, this is Akriti Sharan. You have. Yeah, first I'll answer Srijanya Tula's question. 4 to 5 hour surgery will not cause thromboembolism proper. It will cause deep vein thrombosis, and if we have not looked into it, probably it will dislodge and cause pulmonary thromboembolism. It is more DVT which is causing pulmonary thromboembolism. And then once more, complaint of patients with varicose veins. The more common complaint of any varicose veins patient is dragging type of lower limb pain, because it takes place at the end of the day. Why? Because in the morning the blood column is just getting filled, and by the time it's evening, the legs can't take it anymore, so they'll present with pain. Then the complaints will be thickness of the skin, irritation, that is itching, probably an ulcer. Most of the times they'll bear the pain and then they'll come in a stage of ulcer to us. Most of the times. Some people who are very conscious, yes, they will come to you with varicose veins, which you can treat at the earliest and then do it. The other modalities of treatment of varicose veins is radiofrequency ablation, but the problem with radiofrequency ablation or sclerotherapy is you can only do for perforator incompetence. You cannot do for SFJ incompetence. SFJ incompetence, the only treatment that are available are your flush ligation and stripping, that is Trendelenburg surgery, and endovenous laser surgery. Endovenous laser surgery has a little recurrence chances, but the patient's quality of life is very nice in endovenous laser surgery. Radiofrequency ablation, it's nothing. You will send a probe, and that will change the frequency, injure the endothelium, and the vein is compressed. Then you apply a bandage and they get fibrosed and heal. So you will have the chances of recurrence are very, very high in both sclerotherapy as well as radiofrequency ablation. To an extent, they are little minimized in endovenous laser surgery, and the best is probably surgery, but the only problem is it is cumbersome. The patient has to be put on crepe bandage, 48 hours of bed rest, and the ulcer, and the wound healing This is all a big process. The patient will almost need to be 12, 13 days of hospital roaming, and that's the reason these days people are preferring endovenous laser surgery, taking less pains, and you can immediately go and join your job back in about 3 to 4 days. But the thing is, it's costly. The only probe, the varicose vein probe that they're going to burn will cost you about 60,000. So it is a costly procedure. You have to think about the costs also. Done. Srijanya, hopefully I answered your question. Akriti Saran. So it's the pain followed by ulcer, and then you can ask about itching. What are the timings that the patient is having pain? Whether the patient has any swelling in the abdomen. Whether if it's a female, did this come to you during your pregnancy? And uh, what else? Color change, skin color change. Is it itching? And then you should ask about bladder, because bladder also is a pelvic organ. Whether the patient has any hematuria, whether the patient has any night frequency, because prostate cancer, most of the times it is high. Most of the times it is night. Or nocturnal nocturia that the patient presents with. So yes, you have to ask. Okay, fine. Thank you. In the next class, whatever is left over, and maybe a little detailed questionings of what are the questions that will be asked in varicose veins, and we'll finish our varicose veins, and then after the class next will be your lymphatic system. That should be one class, and I'll see if I find any more questions for both arterial venous system, and then that we will do it in anywhere this time. Next class we should be easily finishing varicose veins. Venous systems. Okay. See you all. Bye.